I just have the heart shouldn't take long, a little bit of introduction to blood, which we'll incorporate probably by Friday and Monday of next week, so we can do the blood lab, and that's my focus. So I really think where I left it, I really think the single most important set of slides are these two that come into understanding what the heart is. So let me go back. It's hard to see. Oh, pretty. So what they have here is you're trying to marry. I don't get excited.
I just had to open my chips.
Of course.
Yeah.
What kind?
They're taco. Okay.
Sir, I can't do this anymore.
Well, I'll have them for you.
No, you're good.
In spirit.
I got it.
You like a Sour Patch Kid?
No, I can't do it. I can't even walk into Badger's office. I can't go in. He's surrounded by candy. It's candy I like. It's awful. What a nice guy. Okay.
He's gotta work on.
Okay. So this part of the chart basically takes you certain things. So you're seeing here, what you're seeing in green is a curve of pressure within the aorta, outside the heart. What you're seeing in blue is ventricular pressure. What you're seeing in red is atrial pressure. And so you can see a couple of interesting things as well as the heart sounds. So what you're going to see basically, as the heart begins to fill, there's really limited pressure in the aorta and limited pressure in the ventricles at rest, at diastole of the heart. As you will see, when we hear the first heart sound, and we're going to marry in the EKG shortly, the first heart sound comes, and you'll see it should be on the next slide, right about here. And that's going to stimulate the filling of the atrium. So we're going to contraction of the atrial system. You're going to see that it's going to polarize. You're going to get a little bump in both the atria and the ventricles, not really that appreciable. In the aorta, I mean, those valves are closed. The pressures only go to one direction down. As it completes it goes through the P wave, it starts the QRS. Two things occur. We begin to get filling of the left ventricle. And so when we begin to see the pressure begins, the left ventricle rather is more or less filled, now it's starting to pressurize. The first thing we notice when it pressurizes is the first heart sound. As the pressure builds up, it slams those atrioventricular valves closed. It's loud. That's the big lug of love though. The pressure rises continually, and as you can see, the atrial pressure, which increases slightly with the closure, really doesn't do a whole lot after that. It just basically stays fairly low. It's really a low pressure area in the heart. But you see it rises until it starts to roughly reach that 120 value for most of us, but it's whatever the value it needs to force open. Okay. So it needs to force open the aortic and pulmonary valves. Pulmonary is a lower system. So once the aorta opens, you can be sure the pulmonary one is open. And immediately, the volume starts to go down. It ejects relatively rapidly. Yet, we don't have, when we look at pressure in the aorta, it doesn't go up and down and up and down. That's because we get this phenomenon called the dicrotic notch. In the dicrotic notch, which we don't see with the test that we're doing today. Okay. The dicrotic notch is a product of that rebound phenomenon. As it overcomes aortic pressure, those are elastic or conductive arteries, rich in elastic tissue. They're pushed out. When the pressure starts to get, it rebounds, and it pushes the blood not only farther along toward the body or the lungs, but back. It closes the aortic and pulmonary semilunar valves. And by doing so, as the blood is rushing here, the contraction is going to push it out to the body, push it back closing the aortic valve, and it's going to rebound. Just like waves coming into the shore, the Atlantic, it's the undertow. It hits hard, it comes back off, and it's like a secondary pressure wave. You know how you can get pretty turbulent, knocked over, even in the surf, there, comparatively speaking. And what that does is it basically, as you can see, if you sort of project this in your mind, we don't get this sharp up and down. High, little dip, high, little dip. So it sustains the pressure without undue turbulence. A lot of up and down, and it makes sure, and the blood's got to go a long way. It's got to go from your heart all the way to your fingers and your toes, deep into your kidneys, etc. You've got to have sustained pressure for all of those structures to work. So we don't get the pulsatile nature of flow in the aorta. We get a more gentle, consistent flow, and that eliminates turbulence. That's the big player with that. The distinction here is we marry in the P wave. So again, electrical activity when the pacemaker starts. Again, the aorta's going nowhere. We start to see that little bump in pressure in the atria and the ventricles. You can see it's passively filling because the pulmonary and semilunar valves and aortic semilunar valves are closed. The atrioventricular valves are open. It fills, it rests, it fills. And then this is that little top off. That's what the P wave is doing, maximizing ejection pressure and maximizing efficiency. Then, now when the QRS starts, we begin to do very, very rapid, powerful, overcomes it, forces it open, down it goes, dichrotic notch. And as it starts to go down, we begin to see the T wave, which is highlighting basically the ventricular repolarization. And because those ventricles are large and muscular, we get an appreciable wave in both. Down at the bottom, you can see how the volume goes up and the volume goes down. The volume goes up and the volume goes down. Those are the slides when you marry them together. And they used to put all of it on one slide. So underneath the lower part of this slide, underneath the heart, you have heart sounds. So you could really look at them and appreciate them all at once. And that's one slide that explains a great deal of cardiac physiology in the context of what's happening with the volumes, the fact that the dichrotic notch is not an electrical phenomena, but a pressure wave phenomena, okay, in the aorta, not anywhere else, but very unique area. And then and you can marry the heart sounds and the volumes, et cetera, et cetera. That's it. So I particularly like that particular slide, or two slides. Here's the lub-dub, et cetera, et cetera. And I don't ask me, I'm no good. First, my ears are terribly clogged today. Don't know why. Been that way since 9 o'clock this morning. Everything is like an echo chamber. My little spray nasocort was all clogged up. I hadn't used it in months. So the heart sounds you could hear, and if you want to hear them or learn about murmurs and things like that, there's plenty of that available. I'll bet you there's nursing people who would help you if you're really curious about that. I do not have the ear for it. Not me. So where we can, and this is where we identify sounds clinically, though we're not going to do it. The aorta, you remember anatomically, the valve structure is a little bit, remember aortic and pulmonic valves are higher up because of the way the muscularity of the ventricular chambers, and they eject more superiorly. And then the atrioventricular areas, really their sound is a little bit different and they're lower. So and again, the different kinds of murmurs, typically indicative of valve problems. I mean, you can have them, you can be born with them. The most common for years had to do with rheumatic fever. And rheumatic fever is a streptococcal infection. And you guys didn't have the medical micro part, the clinical micro. Streptococcus is more about your immune system attacking things. It's very immunologically stimulating. And it creates antibodies. And the antibodies can't tell the difference between a strep and a joint and the lining of your heart, and particularly around the valves. So you get damage. So that's why they call it rheumatic fever, rheumatism, the old term for pain in joints and things like that. So it maintained the name, and there's worse presentations like scarlet fever, which has more widespread toxins. is really almost due to an almost unusual, atypical response of your immunological system, and that's streptococcus that does that very well. Very interesting. Bless you. Fascinating thing. That goes on. Why don't we see it as much? We have antibiotics. And so that's why moms and dads the world over, and if you guys are in that particular position, remember, we didn't go to the doctor. Doctor cost money. We didn't have health insurance or no such thing as that. You had to be near death to go see a doctor. And but moms were great. They get the flashlight. They do something as a tongue depressor. They look in your throat. If it looked red and it smelled like you were on a 3-day drunk, which was fermentation, which is streptococcus, you're going to the doctor. If it didn't look like that, hey, most likely you're going to school. Good luck. Yes.
I just found out today that strep can turn into necrotizing fasciitis.
Neck fascia.
Why?
It's a different kind of strep. They're all okay. The name of that streptococcus is called Streptococcus pyogenes. Means pus producer. It has genetically, it triggers, just like scarlet fever, this excessive immune response. Okay, it is, the name is on the tip of my tongue, and we'll go over it in the immune system. What is these particular toxins, you've heard of toxic shock syndrome, which was famous back in 1980 because of tampons. They were using a high absorbency tampon. It's the same thing. It super activates 20% of your helper T cells, and they produce a slew of chemicals that cause massive problems. And necrotizing means, interestingly, if it leaves bone alone and skin alone, but eats everything up in between. So what a necrotizing means turns into liquid. I've seen 2 cases. Okay. And so that was the old flesh eating. And there's other bacteria that do that. There's one out from the men who were over and the women who were over in Desert Storm that Acinetobacter occasionally and there's other agents, but Streptococcus is the most famous. So it's a real oddball on his skin. The most common skin infections: Staphylococcus, Streptococcus, Pseudomonas. Those are the big players on your skin, by far. I don't know if I answered your question. I'm trying to remember the name of that phenomena, and we do it in immune, so it's one of those. I hate that. My memory's going. I might actually forget my name. That worries me more than anything in the world.
I think you're just having a bad day.
I missed one thing and I'm having a bad day?
Maybe. Allowed. You're allowed to have a bad day.
Never. If I don't have this, what else have I got? They're not choosing me first in the pickup basketball game. Oh, no, not unless the only thing is they need to put me in goal for a goal, just because I'm large enough. In a hockey game, I can't skate. Tug of war, I was always the last guy.
The anchor. That's the most important part, though.
Tell me about it. Even I used to weigh like 70 pounds more than this, so I can relate.
You're funny.
Haha or peculiar? Both.
A little bit of both. You're good mix. It's the best parts of both.
Bless your hearts. Okay. Moving on. So we talked about valves and their anatomy a bit. Incompetency or insufficiency are a little bit different. So incompetent means they just don't close well. Insufficient might imply that not enough blood is getting through. That's more so with stenotic. Stenosis means narrowing of any structure. It isn't peculiar or unique to heart valves. And the sounds are different, which I don't do. This is the physiology part. Cardiac output is the companion of what we call minute volume. Cardiac output is measured in liters per minute or milliliters per minute. Average heart rate is 75. Average volume each time your ventricles eject blood is 70. You do the math, 5 1/4, 5.25. Your lungs are the same thing. The amount of 12 to 20 times you breathe during a particular minute, and that your tidal volume, which we'll look at with this machinery, subsequently, if you do the multiplication, you get the same amount. So your cardiac output is always married to how much air you're moving in and out, because theoretically, and not even more so, even reality, you're going to need, if you have 5.25 liters of blood you're pushing around, you're going to need 5.25 liters effective of air that's oxygenated to reoxygenate the blood, period. And everything is balance. Inequalities on either side, either lung, either part of the heart, are doomed to failure. Famously in Kung Fu from the 1970s, balance, grasshopper. No Kung Fu fans? So, cardiac output 4 to 5 times is max versus your resting in me, non-athletic individuals. And what athletic training does is you can increase that to roughly 7 times. And that's what training is about. And there's so many different kinds of training. I marvel at people who are able to do those things. I just absolutely marvel. There's a guy I mean, he must weigh 140 pounds, soaking wet with his clothes on the soccer team I support, Manchester, who played the most minutes of any player in Europe, Bruno Fernandes. He never misses a minute. He can run 10 miles constantly oh my God, it's ridiculous. And so we look at the cardiac reserve in someone who's trained. And so and that's the whole idea of training, gets your heart rate low, and you have a lot of reserve. Your heart rate and your cardiac output can accelerate it with changes in either stroke volume or heart rate. And so those are the big players that are there. And with training, by lowering your heart rate, you have so much more reserve that you're able in a high stress situation. I mean, it's a little different when you're doing cardiac from a rehabilitative, or like for me, what a senior would do. I know, that hurt. Don't start.
I didn't say anything.
As my wife says, get your skinny, you know what, to the gym. She doesn't go for that round as a shape anymore.
No.
No.
Sorry.
Yeah, I can't win them all. And you're going to see that's when we talked about aerobic activity, marrying heart rate and breathing, switching muscle usage. And what you're doing by strategically increasing your heart rate is you're stressing it in a very scientific manner. And if you're able to do that somewhere between 3 and 6 times a week for about 30 minutes and get roughly 80% of your maximum heart rate, and there's a lot of ways to develop, there's accurate ways and inaccurate ways, but it's age related. So somebody like me who's going to be 73, I know, hard to believe, not one of you raised an eyebrow. Oh, thank you for saying it couldn't be true.
So how does, I guess, like cardiovascular stuff not cause like hypertrophy of the heart, but when you're not doing it, it'll lower your heart rate, like does the heart get stronger without getting larger?
Yes. Ask the question again. Just let me so I can get it the right
Yeah,
answer.
I was like, so when you're doing like cardio,
Right.
Your heart's going, and you don't want it to get bigger like a normal muscle, but it's still.
Yeah, you're scientifically you're increasing muscle mass, but by doing it aerobically, you're increasing blood supply and increasing the amounts of collateral circulation. All those anastomoses you might remember from earlier in this chapter, you increase those past. And for someone, let's say, who's already had heart problems, now you are able to, how should I say it appropriately? Now you're able to decrease the likelihood they're going to have an event. Because even though one vessel may be damaged, you don't necessarily need to go in there and do something if you have enough collateralization from that. Now, a lot of times they'll marry that with like somebody has a stent procedure because it's less invasive and you can expand and then put them on a rehab program.
So it kind of gets more efficient.
It's more efficient and it's better circulation. It's really what happens. And it's a fine line. Look, when I used to go over 140, my target's like between 120 and 140. So once I get to 130, I start to feel it. I mean, if it gets any higher than that, I'm just taking down the height, lowering the speed. So if I can do that, when I was doing this a lot, I was doing 3 miles an hour, like 6, not miles an hour, like 4, and 4 walking a brisk walk, an elevation about 6 or 7. Now, 3 or 4 is fine. I'm sorry. Can't do it like I used to.
Oh, I'm not upset. You're good.
I'm trying. So, and these are all the different factors with cardiac output. So things that you're going to see are important. Adequate venous return, the underestimation of the importance of good veins to bring it back. Increasing that end diastole at rest without any effort, filling the heart. Increasing contractility, basically being efficient with stroke volume. So I don't know that you usually have to reduce it so much, but these are things that can impact it. And then sympathetic versus parasympathetic. Again, sympathetic is force of contraction and heart rate. So this is what we look at. And this is the ejection fraction. And these are the important things. So the ejection fraction, it's 4 ounces a chamber. And we eject 70 mils, roughly 57% when you cranked out the numbers. It's not terribly impressive, but for us, it's impressive. And so we have to look at how well it's loaded, how the contractile nature of the heart, and how much we have left. And now we get into some names. Okay. The degree, and this is a very important one, the Frank-Starling relationship between preload and stroke volume. How do we get muscles to work better? We stretch them a little bit. They have stretch receptors. We want to get to an optimal distance. And again, like we learned about in muscles, not overstretched or understretched. Okay. So preload to degree to which cardiac muscles are stretched just before they contract. And so it can alter stroke volume. And it affects how much you're going to have at end diastolic volume. And they call it Frank-Starling. So it's the length tension relationship. At rest, cardiac muscles are shorter than they need to be optimally. And so by filling it sufficiently, appropriately to the levels you were seeing before, when the heart rate is normal and there's no arrhythmias and there's good venous return and you're not dehydrated, pick any condition, you're going to have an optimal amount. You just want it to keep working. So the most important factor is that preload, and that is basically venous return. Okay, slowing the heartbeat and exercise increase that. That's why they're so useful. This is where Lou doesn't always practice. I'm more active now than I used to be. I've told you, I didn't see the inside of a gym until I was 55 years old. Perspiration. I'm going there. He goes, "You want to see the locker room?" I said, "No, must I?" Just what I want to see is a bunch of guys naked running around. And they wouldn't let me in the ladies' locker room.
Well, probably for good reason, Dr. Stein.
Yeah, I understand. Pervert. But it is a good word.
You like that word?
I like saying it. I don't want to be.
I was going to say, let's tread lightly with this.
I don't want to make an implication that I, behave inappropriately.
Yeah. Okay.
You know me. G-rated.
I know.
Your recordings today are going to be interesting.
I may delete them and re-record them. So the venous return basically increases end diastolic volume, and by doing so increases stroke volume, and by doing so increases cardiac output. That's the Frank-Starling. Stretch it appropriately, you're going to get maximum return. Contractility, independent of how much you're loaded. So it lowers the end systolic volume. Okay, so you're going to eject more. Eject more is efficient. Epinephrine can do it. Calcium influx, cross-bridging. So the term for increasing contraction is inotropic. Positive increases, negative decreases. Things that we see a lot. Thyroxine, which we just started to talk about, thyroid hormone. Glucagon, which we will, which increases sugar. Epinephrine. We don't see, I haven't been writing on hospital charts and taking patient histories for years. We used to use digitalis alkaloids were the main. Now there's a whole lot of other medicines. Trouble with digitalis it was ideal because it did all of these things. Okay, it increased rate of contraction, it lowered heart rate. The problem is that when people were using that with diuretics, there was really some problems with potassium. That was it. And so extracellular calcium, again, calcium for the heart, mostly from outside the cell, versus negative acidity, a lot of lactic acid, too much potassium, and what a lot of people take, myself included, calcium channel blockers, which are there more for blood pressure as opposed to heart related. But it's one of the things you would basically with an incipient heart attack. You think someone's having a heart attack, they give them calcium channel blockers right away in the emergency room. You're just trying to slow down the horse. And I mean, you can look through this as well as I can look at it and see what all the different things that occur when we have norepinephrine along the chain of activity that's there. What's left? The afterload. The back pressure exerted by arterial blood that ventricles must overcome to eject blood. So pushing on the semilunar valves. Aortic pressure is around 80, pulmonary trunk around 10. It obviously typically maxes at 120. Hypertension affects this. And so it makes it harder for the heart to empty. So you have greater end systolic volumes and reduced stroke volumes. That's the tragedy of high blood pressure. We deal with that mostly in the blood vessel unit. It is extraordinarily common. And it's something that typically hits people later in life, but not everybody. Okay. So, I mean, I have some, but I never had to take medicine until I was probably 40s to 50s for that. And now I take two that are comparatively mild. So if stroke volume is a result of decreased blood volume or a weak heart, you can deal with chronotropic agents, basically to raise or lower it. So typically, what we're trying to use the autonomic nervous system to lower it by being well conditioned, have vagal tone. Chemicals and other factors can play a role. A lot of things activate epinephrine or norepinephrine. Norepinephrine is released and binds to again, remember these beta 1s in the heart, pacemaker rapidly, so it's positive chronotropic, chrono for time or heart rate. End diastolic volume is decreased because the rate's going faster, and so even though you're pumping it out more quickly, you're not allowing enough time for return. Okay, and even the end systolic volume, because it's irregular. It's not necessarily desirable, but it may be necessary depending on where you are, what you need to have your heart accomplish, how much has to circulate. So both the end diastolic and end systolic volumes decrease. Stroke volume can still remain unchanged. The parasympathetic nervous system, which we all know, opposes it. The acetylcholine actually hyperpolarizes those pacemaker cells, openings up more potassium channel, harder to reach threshold, little or no effect on contractility. So it's by definition that vagal tone and acetylcholine has nothing to do with inotropic, positive or negative. Here's the vagal tone, and typically, for most of us, it takes the heart rate. Again, it's the governor. The fitter you are, the better your heart is governed, and it's very desirable. And typically they opposite each other. The sympathetic reflex initiated by increased venous return, hence increased atrial filling. It's called the Bainbridge resets. So atrial walls get stretched with the increased volume. The SA node increases heart rate, it stimulates atrial stretch receptors, activates sympathetic reflexes. So there's certain things that we do begin to see. And I'm not as familiar with that topic as any other that are there, and you can look through that. Those are more neurological phenomena, again, with sympathetic or parasympathetic nerves. These are the chemicals. Epinephrine bolsters what fight or flight does and the sympathetic nervous system. Thyroxine increases heart rate, and in doing so increases, so it's sort of synergistic, if you will, or permissive, if you will, with epinephrine and norepinephrine. Calcium and potassium have to be there. And this is a big problem. This one we look a lot at those positively charged particles again. Your K and your calcium are so important. That's the kind of thing, if you're ending up in a medical field and you're a resident, or depends on the venue. Years ago, the medical school said they would work these up like crazy. It's unfortunate the population they used, and I say this sincerely because we were part of it in the rotations I did individually and as a group, were veterans pop, were VA hospitals. VA hospitals used to be a lot better. A lot of good people liked VA hospitals. And I mean, there's some shocking stuff that goes on, and it's past criminal, heinous.
The VA hospital in Oakland's real nice.
It improved because it wasn't.
Mm-hmm.
It improved.
For the past like 10, 15 years, I've seen it get a lot better.
There were so many problems here. They had an outbreak of Legionnaire's disease, which is based in water systems. It went from the domain. A lot of really good doctors like that because of those things. You were more free to do tests. So you'd work up things. You do a lot of studies. The one I was with the McGuire's Vets Hospital and did a summer there in Richmond. It was one of the best experiences I ever had. A lot of walking. It was all like a series of like Quonset huts that were interconnected with hallways, some inside, some outside. Oh, it was great. It's fabulous. I learned more in those 2 months than I did in a year of school. It's great. I mean, I'm all of a sudden I'm like, I'm vain. Okay. And so for you unfamiliar with, when doctors go for residency programs, you sit in like a conference room and everybody fires questions at you. And you got to have the answers. There's no notes. They just bang it. And I answered every one time. I smoked them. I walked out of there going, yeah, baby, try me. Ask me a question I can't handle. You're feeling lucky? And so it was Clint Eastwood. Okay, so moving on. So if your calcium is low, you don't have calcium for your heart to both contract as it needs it and for your heart rate. And it's a little bit, and understand, it's funny, these sometimes have different roles EKG wise, where we see evidence of calcemia and kalemia. Hyper K can certainly block the heart when you have too much of this. The one that is really the worst is hypokalemia. Low potassium, everybody goes low on either one of these. People go crazy. Sure.
Why, if you have like low magnesium, does it affect your lungs?
It does too, yes. And a lot of times it coincides with low calcium. And a lot of times they'll add magnesium. It seems to stabilize muscle activity, particularly cardiac and smooth muscle. So a lot of times they're throwing magnesium in a lot.
What's the role of magnesium?
To explain to you honestly, I will look it up and let you know specifically. I know they use it adjunctively. For instance, right now, I take a magnesium at night because every so often I get like Charlie horses, spasms, and a lot of times it's electrolytic imbalances. So I know there's a certain inherent stability to muscles that comes from it, but I don't know this. I can't explain to you scientifically, and I should be able to. There's a short answer for that. 3 little words. I don't know.
That's a good answer.
It's always a good answer. One thing is, you guys have been around the block there for a while. Okay. You know when a professor's BSing. Yeah. So you can't bullshit a bullshitter. Did that go in? Other factors. Babies faster. Fetus fastest. Women faster than men. Exercise, obviously. But trained athletes slow it down. Temperature increases it. So if it's over 100, by definition, tachycardia. Bradycardia, unless it has to do with somebody who's doing training appropriately, too slow. Whenever there's an imbalance, whenever there's an irregularity, this is what we worry about, failure. Congestive heart failure, and it's just that. It's ultimately a pump, and it's a 2-chamber pump. If one chamber fails, it's backing up, just like the toilet got clogged. It's going in the wrong direction. Okay, so the cardiac output is low and it's inadequate. So that's what it means. It's failing to get enough cardiac output to meet your needs. Normally, it's myocardial weakness. Most common cause, surely, atherosclerotic heart disease. And atherosclerotic, our atheromas are fatty buildups that form because areas within the lining of the heart have were exposed, developed clots, start to repair themselves, became inflamed, and it sort of underlies the lining and creates little humps and bumps, and that makes turbulence, and clots can adhere to it. And as they do, now you have the impairment of oxygen getting through. It's too narrow. So ultimately, again, nowadays with stent technology, we can put a catheter in, slide something over it like effectively a balloon, inflate it, and push the stuff to the walls. Push all that junk back against the wall, recreate the opening, and then slide something to retain that wall. The analogy I always use, as I grew up in what we call the high hair days for ladies, those rollers with little things on them. You know what I'm talking about? My wife uses hot rollers, but the ones that have like little pins coming out. And my sister and my mom were the high hair days, the big hair dryer that fit over it.
The curlers.
Yeah, still is. I have enough hair to make a difference. You don't even need the curling on.
Yeah, I don't know about that. I'll take your word for it.
My daughter's a flat iron person. High blood pressure. So we asked about this before. It causes the myocardium to overwork. And that chronic increase, the chambers get smaller. Okay. And what happens is eventually it doesn't eject it as favorably. You end up with effectively a chamber that is, again, inadequate to be able to contract. Myocardial infarctions, that's a heart attack, death of heart muscle due to inadequate oxygenation. And all those cells that contract are now scar tissue. The more you have of that, the less likely it's to function. Cardiomyopathy. There's a lot of reasons. Sometimes there's genetic-based ones. There are ones that are certainly toxic-related, inflammatory diseases. We start to see, again, that's one of the things you worry about. When those first COVID vaccines, there was a fair percentage of people with myocarditis, inflammatory changes of the heart. Put some of them in the hospital. I mean, I don't know. Frankly, with COVID, they weren't going to report any fatalities. Okay. So, and congestive can be either side. So in that sense, if it's on the left, where's it going to back up to? Into the heart, because it can't get out. Okay. And the left-sided heart failure, where's it coming from? It's coming from the lungs. So it backs up into the lungs until you get this thing called pulmonary edema. If it's in those blood vessels, water's going to seep out. And now all of a sudden you're effectively drowning. On right side, it goes back into the rest of the body. So you might see jugular veins distend. You might see liver overlying the liver. You might see what appear to be varicose veins, or typically you see peripheral edema, swelling. And really what happens is when one starts, the other one's due to come. You get both sides fail. If the left side fails, the right side can't overwhelm the fluid to push blood in there against that vast amount of fluid. It starts to fail. If the right heart fails first, it's not getting enough blood to the lungs. Okay. And the lungs, it can't be reoxygenated. It can't feed the left side of the heart to pump it out. And the left side starts to fail. So any asymmetry in that begins to cause problems. And so there's lots of ways to treat it, and not all of them are effective. Okay. I'm going to take 15 minutes and introduce blood. We'll get a volunteer or two for the technology. There's nothing to it. You're basically just putting those leads on, those 3 leads. They're just placed a little differently. One right arm, one left arm, one on a leg. Wherever my doodad went to. It's a scientific term. You put this over your thumb or over your middle finger. I prefer the middle finger. like this.
Close.
Just, I'm demonstrating.
Yeah.
Don't start.
I'm not-
You don't read anything into that demonstration. I don't like it. Please, I have to go to Sam's Club.
What's wrong with Sam's Club?
Nothing. I gotta get bubble wrap.
Sometimes Sam's Club is hectic. It takes a lot.
Takes what?
It takes a lot to go in there sometimes.
Not me.
I'm not using it now.
But I'm just saying I can't go get pretzels or pieces of pizza anymore.
The free samples.
I know. It's awful. I don't appreciate it anymore. No, I have to get some bubble wrap.
You sending out more Squishmallows?
No. We sold, did you ever see the You Are Here mugs from Starbucks, or You Were There?
Yeah.
We found my wife found it at Goodwill. Ready? $3. It's not new. It's not in the original box or anything like that. It's Egypt. And it has a picture of the pyramids on one side, the big E for Egypt. Huh. Thank you very much. $50 on eBay.
Dang. And those are like usually $15, $20.
Yeah, I know. We were excited. I took a couple of pictures, threw that bad boy on eBay. Happy dance.
What was your asking price originally?
No, they paid the asking price. $50 plus whatever the shipping. It's cheap shipping. Little box, priority mail. Yeah, $8, $10. One day she went into a Goodwill, and they had just brought out a cart that had 15 of those mugs, many of them in the original boxes. Oh my God.
Hit the jackpot.
Happy dance. Going out to dinner. Blood. We did heart first. We'll do blood vessels after. I do the blood in preparation for our blood lab. It's an interest because you got to be familiar with blood, and I'm entirely too familiar with blood. Okay, as I've told you before, I used to have very little wit, but after having 50 to 75 transfusions of other people's blood, 50 to 75 units of other people's blood, I became rather clever and witty.
Believe it.
They used to think that. MASH, if you watch the original MASH, there's a brilliant show. And they had it in the first 3 seasons. They had a man, a typical, and I don't want to paint with a broad brush, somebody who looked like they were going to fight the Civil War. And was telling the nurses, who happened to be a nurse of color, to give him the right blood. They thought that if you got transfused with blood from a person of a different race, you might change. He did not know that the person, that it was a man of color in the South who was the one who was able to effectively develop the technique for transfusions, for blood transfusions. Sir.
How do people transfusing the blood, how do they know like the blood is like suitable?
Oh, we're getting there. That's coming. It has to do with markers on the blood, antigenic markers on the blood, more than the ABO.
No, like it's not like contaminated or anything.
Pardon me?
Like,
Oh, yeah, it's tested. It's tested.
doesn't know they have.
It's tested extensively. Right now, and I'll frame it this way. Years ago, okay, blood bank blood up until 1987 was a problem. And you're looking at a family who was living proof of that problem. My wife had a transfusion, my first wife, in 1981, because she had a bleed because of this bleeding disorder, which is a variant of von Willebrand's disease we'd spoken about a little bit earlier. It's a platelet problem. And they're trying to wedge her over. She's trying to have kids. And a brilliant, just an absolutely brilliant OBGYN, who I'm sure is retired by now, who she knew very, very well and had been with for many, many years. He wedged the ovaries. She developed intra-abdominal bleed. They had to give her 2 units of compatible blood. Most likely that's where she was exposed to hepatitis C. After all those years, after being a nurse, being a dialysis nurse, where you were really at the time worried more about hepatitis B, We didn't know about hepatitis C, but it was there. And after 1987, with the advent of increased amounts of HIV and hepatitis C, the blood banks kind of redid everything and began to really look at the blood. People always used to, the safest blood, auto donation, putting blood aside for yourself. Like you're going to have a hip replacement. You need blood. The next safest blood bank. The next safest blood, directed donation. Oh, my Uncle Charlie and I have the same blood type. Well, you don't know whether Uncle Charlie's been indiscreet. There's a higher statistical probability of problems with a relative directing a donation than there is with blood bank blood, at least statistically. Statistics are just that. So I thought it's an interesting little way to start the unit. So my context is all the blood I've had. Yet I'm still here to teach you. Okay, pretty obvious stuff. Transport, regulation, protection. Nothing special. Okay, transport. Job one, oxygen. It's like a big sign on your bloodstream. We deliver oxygen. Okay, nutrients come along for the party. We take care of waste. We get them to where they're going to be disposed of after the liver, lungs, kidney, etc. Hormones, we were just talking about that in endocrine. Sure, but again, oxygen is the first job. Temperature, increasing and decreasing flow will affect temperature. Okay, certainly we're going to talk ad nauseum about the carbonic acid buffer yet again. Alkaline reserve, something we'll talk about for at least two systems, both digestive and respiratory, and then fluid volume. So they're all, about that. Okay. So when we begin to look at this, we have to look at the clotting cascade as part of that, the different roles of the three major types of plasma proteins. Okay. And then certainly the protective nature of it, the immune system aspect, antibodies, complement, white blood cells, all of that's part of it. All the different white blood cells, the way complement interacts and its role that it plays, which we revisit in more than one system. We've also revisited immune. Because you guys don't have immunology this term, I do more immunology. That's why I'm probably going to make it a standalone unit. Because when my wife took that test in her AP2 class with me, she threw it at me and said, "What the hell do you call this?" In an affectionate way. We were not a public item, as you might guess. Don't look at me. Don't judge me. It's okay. It's only a 7-year difference in age. 6.5. My kids thought I was dating like one of you guys. Here I am, 55, dating somebody in their 20s. They were not happy with me. It has some interesting ways to describe. They weren't necessarily complimentary. So it's a connective tissue. Everybody gets that wrong. It's liquid. There's nothing in the rule books that tissues have to be solid. They can be liquid, solid, semi-solid, or soft. Doesn't matter. The whole issue is the nature of, you remember we have ground substance, we have fibers. The ground substance happens to be fluid. The fibers dissolve in the fluid. When your blood clots, all it does, okay, is basically initiate a cascade of changes that cause the fibers to no longer to be soluble, but to change and become insoluble, effectively forming a fishnet to catch red cells and form a clot. That's what they do. Plasma is the fluid media, and so you'll see how they separate, and we have a variety of different types of plasma. Everything is dissolved in it, with the exception of red cells, erythrocyte, red cells, leukocytes. We call them white cells. Effectively, a better way would be not red cells, because they really aren't. You didn't see them under the microscope before we had stains, and they looked white. You can see it was a cell, but you couldn't see any pigment. So they call them white cells, and platelets, which are fragments of a little bit of membrane and a little bit of protein granules. And the interesting thing is why we call them formed elements, because the white cell is the only one that is a cell. The rest of them ain't cells, because the red cell was a cell, but it lost its nucleus. And the platelets aren't cells at all. They form a giant multinucleated cell and little fragments break off. Fancy name you're going to see shortly, called a megakaryocyte. Okay. And so what you're going to see shortly is something we can do in the lab if you choose. It doesn't always work in the lab. I hate to have people stick themselves, which is totally elective. Nobody has to stick themselves, or you can all stick yourselves. I don't care. Don't ask me to do it. As much fun as I would have. What?
I said we're all just gonna stay.
I think we should.
Yeah.
Maybe you're away for a game.
Is this like the find our blood type?
Yeah, we know. When we do this, this is a very important measure. It's called the hematocrit. The hematocrit is a very good measure of anemia. It's able to determine the proportion of red cells to the total volume. So what we do in the lab, and this goes to your question about with blood and how they handle it, the first thing they do is they separate, because they can use all the components. And they do the same thing you've done in the lab 1,000 times. They centrifuge it. And as they spin it sufficiently fast, the heavier pieces, the heavier units or formed elements go to the bottom. The fluid is light, comes to the top. The formed elements that are relatively light, but not as light as the fluid, are in the middle. And by measure, it's a cylinder. What's a test tube? Effectively, it's a cylinder. You measure the height of the total fluid in the cylinder. Let's say it's 5 inches, and you measure the height. We're doing it. I know we'll be doing metric, and let's say it was 2.5 inches for the height of the red cells. Now, effectively, it's 50-50. So you can approximate the hematocrit, the percentage of blood by volume that's actually red blood cells. And it's called the hematocrit. In the hospital, we call it the crit. And it's very important because from that crit, and we do a test with it. When you order in the hospital, you order a thing called H&H, hemoglobin and hematocrit. But without doing that, you can divide that number, whatever that percentage is. Let's say it is 45. Divided by 3, and you can approximate the hemoglobin in the bloodstream. So it's really a very important. We don't do complete blood tests, CBCs, every day in a hospital for a patient. Once you have an idea you're looking to see if they're anemic or not, you do specific tests after the initial testing. In between the red cells and the plasma, and we don't see it in our samples because we're filling a capillary tube. Very, very tiny. Is called the buffy coat because it's a buff or off-white color. Okay. And so you'll see it here. This is the classic slide that demonstrates it. So if you had a full-size test tube, 55 to 45 roughly, the buffy coat is negligible. And you just centrifuge it 2 or 3 minutes at the appropriate speed. And we do it with a capillary. I don't have what's called a clinical centrifuge. I have to use like the ones you guys probably use in cell and molecular or genetics or wherever. Those big tubes, I have to put cotton in them and a little capillary tube and snap the capillary tube. And if it works, it works. I don't want to waste your blood. If you don't want to do it, I'm happy camp. So, as you all know, blood is sticky. It's metallic because it has iron. And blood stains. And it's not, there's an old saying with blood. Okay, a thimbleful of blood would turn a beaker, a gallon of water red. So imagine a thimbleful of blood is not an insignificant amount. But if you put that in a full gallon of water, that water is red. Take it from somebody who has bladder cancer. You know what it looks like when that fluid is red. It scares the living, you know what, out of you. And depending on where you obtain the blood, most of the time we get it from a vein. It's a relatively dark red. We used to, in the days before we had that neat little sensor, the pulse ox sensor, we took arterial blood. We didn't have that. We did pulse oxes, didn't exist. Because that's a relatively new technology because you're measuring the pigment as it flows. Okay. So it's called photoplethysmography. big name. And effectively, what we do that now with a sensor, and you're measuring the color as the light and how much it obscures in that tiny device that you put on the tip of your finger. And I actually have one I think we can use if you want to play with it in that blood lab. I'll bring it along. And the other interesting thing about that is in the old days we used arterial blood gases. So if you wanted to know the pulse ox, you wanted to know what the oxygen sats were, you did an arterial stick. You stuck it in the radial artery, brachial artery, femoral artery. I did radial. And what you did was before you stuck the person, you cleansed the needle and the syringe with a little bit of anticoagulant. And you used that anticoagulant, used heparin as an anticoagulant so the blood wouldn't clot. And it had it's almost a reddish pink kind of a color. The color of blood, you can tell when blood's right and it's not right. You really can. I was a victim of that. At one point, my hemoglobin and hematocrit were at a level where I probably shouldn't have been around. Where normal for a man is 12 to roughly 17, mine was 5.5. I was still working on patients. Because it's chronic blood loss. If I had lost 2/3 of my blood, I wouldn't have survived in an auto accident or a ruptured, blood vessel, an aortic aneurysm. But chronic blood loss is different. The range, plus or minus 0.05, around 7.4, 7.35 to 7.45, 8% of your body weight. Why the difference between men and women? Simply stated, testosterone. Okay. Testosterone is an agent that stimulates red blood cell formation consistently. There's other substances that do that. The difference is that testosterone-like substances only come from the adrenal medulla, what we're going to cover next time in lecture, in a small area in women, where obviously not only is it there in men, but they have testes and testicular-based testosterone. And this is the last slide, and we'll do the test. Plasma is generally off-white, mostly water, and a whole bunch of stuff. Proteins, the most abundant, certainly by any measure, okay? And proteins mostly come from the liver, and we're going to look at, there's 3 of them. Albumin, the most abundant, 60%. Globulins, which not only carry fatty materials, but more importantly have immunological function, okay, as antibodies. And lastly, the one that's dissolved, about 4%, fibrinogen, which is a protein. It's just until the clotting cascade changes it, it's soluble and it becomes insoluble. The big role of this, other than as a carrier molecule, and that protein acts as a certain degree of a buffer, not as strong as the carbonic acid buffer, is this: on plasma osmotic pressure. Proteins make colloids. They pull and hold water to them. It's so important. It's the way the kidneys work. Okay, blood pressure is pushing it out. The capillaries, proteins are holding it in. We have to have enough of a difference between those two measures for water to be pushed out, or reversibly, when the blood pressure lowers, for water to be pulled back in. And we'll get to all that. I will cease my blabbering, and we'll do, hopefully with not 1, but 2 volunteers and 2 helpers doing this little bit of a lab. So I will stop the recording here.